Welcome, friends of the Retina Channel Podcast, to another episode of this series. This is our first episode in 2026. I wish everyone a wonderful, wonderful new year. My name is Dr. Kevon Kushan. I'm your host for this series, for those of you who don't know me. And today I have the distinct pleasure of having Dr. Seong Joon Ahn from South Korea as a guest speaker. Dr. Ahn joins me from Seoul. We had a 14-hour time difference, and he kindly arranged that and worked with me on putting us at the same time zone, having this conversation. A very kind gentleman, and I really enjoyed my conversation with him. He talked to us today about maculopathy risk association of some systemic medications. He did a sort of a wide epidemiological study using two widely available databases, one in the FDA system, adverse reporting system, another one in the South Korean healthcare system. And he used these two databases to pick up candidate systemic medications that may cause maculopathy. And you'll be surprised to hear those 5 drugs that we don't normally put in association with maculopathy. And then just to give you some background about Dr. Ahn, he's an associate professor of ophthalmology at Hanyang University Hospital in Seoul, Korea. He's a vitreoretinal specialist with clinical and research interest in drug-induced maculopathy, especially hydroxychloroquine. He has done a lot of research on hydroxychloroquine and actually been coming up with worldwide guidelines on hydroxychloroquine toxicity and screening. So he's a pioneer in that. He earned his MD from Seoul National University, completed a residency and fellowship training in retina, and also holds a PhD from the same institution. He's a visiting scholar in the Department of Ophthalmology at Duke University. He has authored over 130 articles and multiple book chapters and many awards, including academic awards of the Korean Ophthalmological Society. So I had a real distinct pleasure. I enjoyed my conversation with him, and I'm sure you're going to learn a lot from this eye-opening conversation with Dr. Ahn. So without further ado, this is Dr. Seong Joon Ahn. Dr. Ahn,
Hello, Dr. Kushan.
welcome to the Retina Channel Podcast.
Thank you for having me and Happy New Year.
Happy New Year to you as well. Happy New Year. You're the first guest of this podcast in 2026. So welcome.
Oh, it's a great honor for me.
And is your
It's a
first
great
guest from
pleasure to be
South
here.
Korea. You're the first
Oh,
guest from
really?
South. Yeah,
Yeah.
yeah, yeah. So you're two
Wow.
first here
I'm so
today.
excited to be here.
I'm very
Yeah.
excited to have you as well. Well, thank you for accepting my invitation, Dr. Ahn.
Thank
And
you for
you,
inviting me.
of course, you published an interesting article in JAMA Ophthalmology that be quite wide open eye-opening, for many of us. You identified some systemic medications with potential ocular adverse events, retinal adverse events, maculopathy specifically. And
Mhm.
your methodology was quite unique, and I guess it needs a lot of scientific background, epidemiology to understand it. So I'm glad that I have you here. But to give listeners and viewers a bit of a background, you looked at two basically databases. One was the FDA adverse event. It's an adverse event reporting system or
Yeah.
FAERS system that essentially is a big catch-all network of getting adverse events, and physicians, healthcare professionals, patients, anyone can report any adverse events, real or not, to this system. And then
Yes.
you have South Korean healthcare system. I think it's called HIRA, and that is sounds to be more robust database, and that gave you exposure information as far as I know. But I'm really curious to know the details of it. And based on that, you identified some drugs that that could have maculopathy, and then you kind of tested those drugs on the South Korean system, and you kind of confirmed your suspicions. And so you have the two main drugs that we know of. You obviously identified those, and then you have some 5 candidate drugs.
Mhm.
And to be honest, I personally, as a retina specialist, had not suspected those to be sort of maculopathy associated drugs. So I want to know what you think about it. So thank you for being
Mhm.
here.
Thank you for having me. Yeah.
Fantastic. So what was the
Yeah.
background, Dr. On, for this study? What sort of promoted you and your group to look into this sort of fairly large epidemiological study?
Yeah, that's a great question. And my interest really started from a clinical perspective.
Mm-hmm.
As ophthalmologists, we sometimes encounter patients with maculopathy where the cause isn't immediately clear, and later on, we might realize that a systemic medication is involved.
Mm-hmm.
Over the past decades, we become more aware of drug-associated maculopathies after the recognition of hydroxychloroquine and
Yes.
pentosan polysulfate-associated maculopathy.
Mm-hmm.
They really highlighted that medication-related retinal toxicity might be more common than we thought. So,
Mm-hmm.
what motivated this study was the need for a systematic, data-driven approach to identify potential unrecognized drugs associated with maculopathy.
Mm-hmm.
Instead of relying on a few case reports suggesting potential association, we wanted to see if large-scale data could help us identify these associations more proactively and systematically. This is
Mm-hmm.
what ultimately led to our study.
Mm-hmm. Mm-hmm. And that's definitely that's a very reasonable cost, absolutely. And then your methodology, tell us about going through the FDA adverse event system. Tell listeners what is that system, how long it's been in place, how many reports it gets, and how
Mhm.
do you access it?
Yeah, it is widely accessible. I mean, it is publicly accessible database, and you
Mm-hmm.
can just search from Google FAERS, then you can easily find the site, the website.
Okay.
And let me briefly introduce FAERS. And this is the full name is FDA Adverse Event Reporting System, and
Mm-hmm.
this database collects spontaneous adverse event report. And
Mm-hmm.
usually we use this database for disproportionality analysis to
Mm-hmm.
detect signals. So this is mainly used for identifying drugs that are reported more frequently with specific adverse events than expected.
Okay. So
Mhm.
just go over that term one more time, disproportionality analysis. You use that a lot in your article as well. What does that
Yeah.
mean?
That means if we use report odds ratio for the measure of disproportionality, and if ROR value has is over than pre-specified value, namely 2, then we think that these drugs uh, are reported more frequently with specific adverse events than expected.
Okay. So I guess it
Mhm.
means this particular drug was disproportionately more reported. That's what I mean. So
Yes,
you essentially looking for
exactly.
signals of more frequency, more or less
Yes,
in
exactly.
simple terms. Okay.
Hmm. Hmm.
All right. So that's fairs. And
Hmm.
then, so you went through fairs and picked up maculopathy associated with some systemic medications. You have a table in your article that you picked up a lot of
Hmm.
things. You picked
Yes,
up
yes.
like pentosan phosphate. Obviously, that's one of the top candidates. Probably
Hmm.
the most frequently reported medicine here,
Yes.
hydroxychloroquine. But you also had
Hmm.
other medications like ranibizumab
Yes.
or insulin or aflibercept
Yes, yes.
or etanercept. A lot like you have a list of 30 medications associated, and then you
Hmm.
picked five of them, right? And I
Yes.
mean, you go
Yes.
over them
Yes.
again. You have fingolimod,
Hmm.
apixaban,
Hmm.
paclitaxel, and
Hmm.
ibrutinib. Those are the
Yes.
five medicines that you identified as potential targets.
Hmm.
How did you choose those five medications of all those 30?
Uh, as I mentioned before, we used ROR over than 2 for the uh, most important criteria for selecting candidate drugs. And
Yes.
actually, some candidate drugs are not actually associated with maculopathy. For
Mm.
example, insulin is used for diabetes, and
Yes.
diabetes may lead to diabetic maculopathy, such as diabetic macular edema. So
Right, right.
we need specified criteria to
Mm-hmm.
exclude some medications that are related uh, not to I mean ocular adverse events, rather than this is the indication for the medication use.
Gotcha. Such as Lucentis, obviously used for
Yes.
macular edema, so it doesn't. Okay, fair enough. So you essentially, if there are any crossovers with other conditions or known diseases, you will take him out.
Yes, exactly.
Okay,
Yes. And yeah, there are other criteria, but these two criteria are the most important one. Uh,
gotcha. And then, so you were left with five medications, and you seven really, seven medications, but two of them we know about, hydroxychloroquine and pentosan
yes,
phosphate. So you have left
yes.
with five other medications. I mentioned them,
Hmm.
what they are. They're not common in ophthalmology. Would you
Yeah.
mind telling the listeners just very briefly what are those medications for, and what did you do with the next step of your project?
Okay. Yeah, in the FAERS analysis, the strongest signals came from drugs we already know can affect the retina. One of the
Yes,
big ones was pentosan polysulfate, which
yes,
is commonly used to treat interstitial cystitis.
yes.
And but what was more interesting though was that we also picked up signals from several drugs that we don't usually think of as being linked to maculopathy. These included
Mhm.
fingolimod, apixaban, ibrutinib, paclitaxel, and sildenafil. And let me
Mhm.
briefly explain what each of these medications is commonly used for.
Thank you.
Fingolimod is prescribed for relapsing forms of multiple sclerosis.
Hmm.
Apixaban is a widely used oral anticoagulant, most often for stroke prevention in patients with atrial fibrillation.
Hmm.
Ibrutinib is a targeted therapy mainly used to treat blood cancers, such as chronic lymphocytic leukemia and certain lymphomas.
Hmm.
And paclitaxel is a commonly used chemotherapy drug for cancers like breast, ovarian, and lung cancer. And
Hmm.
sildenafil is best known for treating erectile dysfunction, but at
Hmm.
different doses, it is also used to treat pulmonary arterial hypertension.
Yes. Very nice. Okay. So essentially, of those five medications, one is sildenafil for erectile dysfunction and pulmonary hypertension. Two are
Mhm,
chemotherapy medications, one for leukemias, one for solid tumors, and
mhm.
one is an MS medication. Fingolimod is an MS medication, and then you
Yes.
had very common anticoagulant, apixaban, or Eliquis is a brand name, very commonly used, at least here in Canada, for
Yes.
blood coagulation issues. Very nice.
Yes.
So you have these
Mhm,
five candidate drugs, and what was the
mhm.
next step of your project? But you took it to the South Korean database.
Yeah. By combining spontaneous reporting systems like FAIRS with encounter data based data, such as health claims database, we can take a more systematic approach to identifying drugs that may be associated with maculopathy, but also for other retinal conditions. So this approach can be extended to other eye-related adverse reactions, such as uveitis and retinal detachment, or specifically macular edema. So that'll be
Hmm.
the next step for our team. So we are currently doing some research on uveitis first.
Interesting, interesting. But for the maculopathy, you used the
Mhm.
South Korean system with these five drugs and you identified exposure.
Yes.
Could you explain to us how did that work? How does the South Korean database work? What it contains? It sounds like a very good system to give you
Yeah.
exposures. Could you tell the
Mhm.
listeners how it works, how long it's been in place, or how accessible is that? Is it free or how does it work?
Okay. Korean national insurance system is mandatory and nationwide, so it can cover almost 98% percent of Korean population. So it
Mm-hmm.
is nationwide database.
Mm-hmm.
So yeah, we don't have any follow we using this database. It is very useful uh, for our study because we don't have any follow-up loss. Because if patient use a different medical center, but we can have all the health claims data from
Mm-hmm.
nationwide medical centers. So yeah, it is very good for following up the patients.
Mm-hmm.
So we evaluate these candidate drugs using nationwide data on users
Mm-hmm.
of those medications. And we
Mm-hmm.
focused on incidence rate ratio, comparing
Mm-hmm.
the risk of maculopathy after drug exposure with the risk before exposure within the same individuals. And
Mm-hmm.
we found that the incidence rate ratio was significantly increased for pentosan polysulfate and hydroxychloroquine first. And so this was kind of a proof of concept.
Mm-hmm.
So we thought that we can continue for other candidate drugs. And so we collected all the data from candidate drug users, namely apixaban, ibrutinib, paclitaxel, and sildenafil.
Mm-hmm.
And we also found a significantly higher post-exposure risk of maculopathy in those
Mm-hmm.
users. And
Mm-hmm.
the incidence rate ratios were comparable to those seen with pentosan polysulfate and hydroxychloroquine.
Very nice. So that sort of provided some kind of a proof, real life
Mhm.
proof that those possible candidate drugs are actually causing maculopathy because a different database reported more maculopathy once the exposure started. And so I
Mhm.
find it fascinating. You had that information in the health insurance system of South Korea. So you knew when the
Mhm.
drug started, you knew, and then the maculopathy reported at different stages. That very nice, very nice. Um,
Mhm.
how important is this information, Dr. An? Are these drugs like, say, a drug like apixaban or sildenafil, very commonly used? Does
Yes.
this information give us about the frequency of these maculopathy? How worried should we be? Should we now
Mhm.
counsel everyone on the risk of maculopathy, or this is more like ground for future work?
Yeah, so for we looked at the actual risk for the candidate drug users, and actually the cumulative incidence ranged from 4% to 15%. So
Hmm.
it's not common, but not rare.
Not
So
rare. Yeah.
yeah, not rare. Yes.
Yeah.
So from a clinical perspectives, I think that these findings suggest that these drugs need further validation. And if these associations are confirmed, patients using these medications may benefit from appropriate education and closer monitoring for possible maculopathy.
Yes. And some of maculopathy sometimes was non-specific, maybe pigment changes. Some of them is macular edema.
Mhm.
Um,
Yes. Especially fingolimod and paclitaxel were associated with macular edema, whereas apixaban and ibrutinib were more commonly associated with macular degeneration.
hmm. So it is 4 to 15% cumulative incidence rate. Sounds like a lot to me. So and you had also some information, maybe dose related, or duration related. So more exposure gave you more risk. Is that right?
Yes, yes, exactly. So, especially for paclitaxel and ibrutinib users, they showed gradual dose and response relationship. So, the higher dose the patient had, the more likely they have that adverse maculopathy adverse events.
And these were two chemotherapy drugs.
Yes,
So the
exactly.
longer chemotherapy and these are causing macular degeneration changes.
Yes,
Okay.
exactly.
Okay.
Mhm.
That is, I think this is very important for a retina specialist to know that there are not just the two drugs we know about, which is pentosome polyphosphate and and hydroxychloroquine. Those are the ones that we commonly encounter. But these are the ones that we don't think cause maculopathy. But your article thankfully shed some light on these possible maculopathy related drugs. Thank you very much.
Yeah. Thank you
Perfect.
so much. Yeah.
Anything
Mhm.
more you want to add, Dr. On? Anything we missed you want the listeners to remember?
Yeah.
What's your take home
So
message, in other words?
yes. Okay. Yeah. This study has some, insight for methodology in drug-related retinal toxicity. So
Mm-hmm.
we use a big database, and
Mm-hmm.
spontaneous reporting systems are very useful for screening a large number of drugs and for generating early safety signals.
Yes.
However, on their own, they can't really tell us about true clinical risk. So those signals still need to be evaluated in real-world population data to validate whether the associations are truly meaningful.
Mm-hmm.
Using an integrated approach with a health claims database, we identified 5 candidate drugs associated with maculopathy and found an increased post-exposure risk with apixaban, ibrutinib, paclitaxel, and sildenafil. So, if we uh, experience some patient with unexplained maculopathy, then we can ask about medication history. And if we have any medication history on these candidate drug, then we can uh, suspect for the cause of unexplained maculopathy as drug-related retinal toxicity.
Mm-hmm. Yeah, yeah, that definitely makes me more cognizant of systemic medication my patients are going to be on if I cannot explain the maculopathy. Well, thank you very much, Dr. On, for doing this great work, for staying up late. I know it's probably past 9 p.m., well into your family time. You stayed up for me to have this
Yeah.
conversation on your Friday night. So I appreciate that. And I hope we maybe see you here in Canada, one of our meetings, or in North America. I hope to see you in person soon.
Thanks again for having me. I really enjoyed the conversation, and I wish everyone listening a happy and healthy new year. Thank you.
Thank you. Same to you. Well, folks, this wraps up episode 94 of the Retina Channel Podcast. I hope you enjoyed this episode and learned from it. I certainly will look for maculopathy or think about systemic medications my patients be on when I cannot figure out the reason for the maculopathy. These five additional drugs, fingolimod, apixaban, paclitaxel, ibrutinib, and sildenafil, that Dr. On's team identified. Definitely, I'll look for them more in my patient's medical history. Well, I hope you all have a great 2026 and lots of good things happen to you. And until the next episode, I wish you all the best. Be well.